Oh, could we dim the lights? Sorry, I've got this light on in the corner here, but for my there's lots of videos and stuff. It's behind that sign. Yeah. Perfect. Excellent. Okay. All right, guys. So today we'll be talking about pelvic ultrasound in the emergency department, both from a transabdominal and an endovaginal perspective. But one thing I want you to keep in mind is that whenever we're doing an ultrasound, the patients are watching us. They're watching to see if we the expressions on our faces, to see if we're being reacting to the ultrasound or not, and any positive or negative feedback we may give them could come up during this scan time. So as you can see here from this video, physicians are filing in and they're watching the ultrasound, and the patient every once in a while looks up at the doctors with some concern. And there's more doctors coming in, and as the doctors look with concern at the ultrasound screen, the patient too becomes concerned, but the doctor promptly shushes her, and her head goes back down, and then the older doctor there, the more senior one, looks at her and shushes her as well. And they're all leaning in now to look at the screen, and suddenly they see something they like. And somebody sent me this. I wasn't sure how it was going to fit into my lecture, but I thought this would be a good spot. So I was just kidding. When it comes to the pelvic anatomy, the female pelvis can be a little bit of a confusing structure. First of all, you've got the posterior cul-de-sac, or what we call the recto-uterine pouch. This is what also known as the pouch of Douglas. It's posterior, and then we've got the anterior cul-de-sac, which is the vesico-uterine pouch. But the problem is that the uterus is seen here at a 90-degree angle to the vaginal vault, and in the normal anteverted uterus we see this angle here, and that already sort of confuses us, not to mention the fact that if you look at this pelvis, it's sort of tilted back from the axis of the body at about 45 degrees, and so there's all these angles and stuff going on. Things get very confusing, especially when it comes to finding the ovaries. We have to remember that the ovaries lie anterior and medial to these external iliac vessels. And so that's why the anatomy, I think, initially is quite confusing in the female pelvis. But over time, I think over today, hopefully, we'll be able to make a lot of sense of it, and the anatomy should be a lot more obvious. Now, as emergency physicians, we have to really take ownership of that first trimester of pregnancy. You see, when a woman has abdominal pain or vaginal bleeding during the first trimester of pregnancy, she's really worried that she could be having a miscarriage, right? From the emergency physician's perspective, we are really worried that she could be having an ectopic pregnancy. And so that's why we have to be actually the true experts of the first trimester, because when women are having complications of first trimester, they don't call their OB/GYN doctors and make an appointment for 2 weeks from now. They come immediately to the emergency department, and putting the onus on us to really know this stuff. So I'm going to get a little bit sort of to the basics here for a couple of slides, and then with the anatomy, as you just saw. Now with some embryology, and what we're seeing here is an ovary, and the ovary's got these follicles that develop, and eventually you have ovulation, where the egg leaves the ovary, and it leaves behind a corpus luteum. When this egg gets fertilized, it has to find the fimbria of the fallopian tube, and it gets fertilized way distally, way out here in the fallopian tube, and it leaves behind this corpus luteum that then helps to nourish this fertilized egg, and it makes its way into a zygote, and then into this morula, and keeps dividing, and finally, like any good parasite, embeds itself in the wall of its host and starts to develop. And you can see that if this fallopian tube is a rocky place where this zygote can get stuck during its development, then you have a tubal pregnancy, which is why we see so many of these. We see 1 to 2 tubal pregnancies a month in our emergency department UCI. And so it's a relatively common thing. Now, in that first trimester, the first thing you can see on an ultrasound is when you've got this thing right here. This is called the yolk sac. It's the first identifiable structure on an endovaginal ultrasound, and it looks like this on the ultrasound. I used to think that was the baby's head, but nope, that's actually the yolk sac. It's this echogenic ring. It's found within the gestational sac. So these anatomical terms and differentiations are important, as I mentioned, because we are the true experts here in this first trimester. So this is the gestational sac out here, Here's the yolk sac right at about 5 weeks. That's the first identifiable sign. So this is the myometrium here of the uterus, and we can see here this this whole structure out here is the gestational sac with this yolk sac here, this being the fetal pole. We don't see that fetal pole here at 5 weeks. We don't see it until about 6 weeks. Okay, so here's that yolk sac, and adjacent to it, what you see at about 6 weeks is this grain of rice or fetal pole. Now, as that yolk sac, you'll see it here. It's starting to sort of obliterate. As that yolk sac gets smaller and smaller, the fetal pole starts to emerge. That's that yolk sac there obliterating. And as we can see, as it's getting smaller and smaller, our little larvae here starting to appear, and it's starting to emerge. This is still the gestational sac out here. Okay, so we've got the gestational sac, we've got the yolk sac, here's the fetal pole, and you can see here from this diagram, these little arrows pointing out, this is actually the amnion, or the amniotic sac, that's growing to take over the contents of the gestational sac. That's what's sort of happening here, even early on. Now, at about 6.5 to 7 weeks is where you start to see that cardiac flicker. We can see it right here, yolk sac, fetal pole, cardiac flicker, and the yolk sac will eventually completely obliterate, and we can see, actually, if you look right here, we can see that amnion. I'll pause it for you here. We can see this is the amniotic sac that's going to grow in this direction, grow out to take over this gestational sac. So we're cool. We got the gestational sac, we've got the yolk sac, and we've got the fetal pole, realizing that we don't see a heartbeat until about 6.5 to 7 weeks. Now, transabdominally, you can't see a pregnancy until it's late 7, really early 8 weeks is when you start to see a transabdominal pregnancy. So, and a lot of our patients actually present before you can see a pregnancy at 8 weeks. They present in that 5 to 7 week range many times with complications of first trimester of pregnancy. So that's why endovaginal ultrasound, one reason why it's very important. And I'm going to go over just a quick another anatomy here of the gestational sac. The gestational, there's something called the double decidual sac sign. The double decidual sac sign is where you have the decidua basalis of the uterus. It comes in contact with the decidua capsularis of the gestational sac. When those two things come in contact, you get this double decidual sac. And actually, radiologists use this double decidual sac all the way down to determine that there is an intrauterine pregnancy as low as 4 weeks. However, this double decidual sac is such a variable finding. It's only present, some people say, about 50% of the time, so you can't really rely on it. And there's something called a pseudo-gestational sac of ectopic pregnancy, where you have what looks like a pregnancy growing in the uterus, but it's just an endometrial reaction to a pregnancy growing on somewhere. A pregnancy growing somewhere in the pelvis. You'll still get a lot of hormonal and endometrial reaction with the fluid collection in the endometrium of the uterus, and that's what's known as a pseudo-gestational sac. But there's a few factors we're going to get to help differentiate between a pseudo-sac and a real IUP, one of which is the fact that we're not going to worry about this double decidual sac. In fact, that's the last time you ever hear me say that. I don't think it's the emergency physician's business to worry about this double decidual sac because it's so variable, it can only get you into trouble. But what we're going to do now is we're going to unlock the mystery of the female pelvis. I'm going to tell you how we're going to image the pelvis, okay? We're going to describe what exactly it is we're looking for in a very discrete and specific way, and we're going to explain why this is important. And finally, as the clinician doing this at the bedside, we're going to explain how you're going to integrate this information into the clinical picture of the patient. Now, there's two ways to image the pelvis. You've got the transabdominal technique, which is where the probe is above the pubic symphysis using the bladder's acoustic window, and then you've got the endovaginal technique, which is when you've got the probe right up against the cervix and much closer to the organ of interest. So some of the pros and cons of both techniques to keep in mind. The transabdominal technique, the pros, you don't need a chaperone because you're outside the vaginal vault. It's less invasive, and it's you get a pretty good sort of field of view. You know, you're looking from above at structures down below. So if you have a really large, let's say, ovarian cyst, you know, I had a patient who had a 19-liter ovarian cyst one time in bed 26. I put the endovag probe in, and all I saw was just, you know, black on the screen because it was just anywhere I looked, it was right up against the cyst. But transabdominally, well, now I can kind of trace that cyst and see where it went and all the way up into the abdomen and measure it and stuff. So you get a kind of a better bird's eye view transabdominally of something really abnormal. But the downside is that because we're using a low-frequency probe, we don't have that nice resolution. We lose some image quality, and this is uncomfortable to the patient. Imagine drinking a 12-pack of beer, okay, and then and I look straight at Mervis, I don't know why, but then you take your belt buckle and then you cinch it down over your bladder. Because that's essentially what we're doing to these patients. We're making them have a full bladder, and then we're pushing on their full bladder, and that can be incredibly uncomfortable, as you can imagine. Whereas with endovaginal ultrasound, it's more comfortable in the sense that now we have an empty bladder, okay? So any urine in the bladder can actually obscure the uterus from artifact, and so that's why we got to have an empty bladder when we go endovag. We get much better resolution because we're basically taking a high-frequency transducer, putting it on a stick, and now we're moving it closer to the organ of interest, thereby increasing the frequency, the resolution by having higher frequency. But the downside is that when you start to do this, first of all, the anatomy looks a little bit confusing because now we're scanning from within the body. Whenever you scan from within a structure, things are a little bit confusing initially. Over time, that anatomy becomes, I think, painfully obvious. But also, we don't have as much depth of view because our high-frequency probes, so we're right up against structures in that near field, not a lot of depth, not a lot of sort of overall perception of what's going on, so it's a little bit confusing that way. And don't expect to see things like the appendix or other pelvic structures that are lying, more than about 8 centimeters away from the end of the transducer. So transabdominally, we'll talk about that first, and this is a review really for most people because it's like the fast scan window. Here's the indicator on the probe. We have that aimed towards the patient's head, and we're basically down right over that pubic symphysis looking in a sagittal view and then a transverse view with that indicator towards the patient's right. As you can see here, I'm using the C60. C stands for curved, 60, the number of millimeters across that probe surface. So this is a big footprint probe. When I have a C60, I will employ it in this fashion in the pelvis transabdominally, as opposed to using the other one, the smaller footprint P21. You can get away with that, but the C60 is really designed for this purpose. It's a better transducer to use if you have it available to you. Here's your C60 indicator towards the head. This is a very full bladder, as I mentioned. It's a triangular-shaped full bladder here. And we can see some other structures here. We can see the endometrium. This is basically the anterior cul-de-sac over here, the vesico-uterine pouch. The endometrium was along here. And then this is the fundus of the uterus back here. This is all that posterior cul-de-sac, that recto-uterine pouch. Here's your cervix here. Here's your vaginal stripe, okay, over here. And here the label's coming out. Bladder, vaginal stripe. This is all the rectum back here. The, again, recto-uterine pouch of Douglas is back here. So the outside world is kind of over here. And then it comes in through the vagina, terminates here at the cervix, and then the uterus comes this way. And this anteverted 90-degree angle here when a woman has a full bladder. Now, when the bladder is not full, when it's empty and you're trying to do transabdominal, well, now you can imagine this fundus is like over here somewhere. It actually anteverts, all the way back like 160 degrees, almost 180 degrees back towards the vagina. Okay, so that's what happens when you have an empty bladder. So when you get a full bladder, you get much better sort of view here using the bladder as your acoustic window. When we move the probe into a transverse plane and a full bladder, now we see this rectangular shaped instead of triangular shaped. In a transverse plane, the bladder is rectangular shaped, and we see the uterus lying posterior to it, this being that vesico-uterine pouch or anterior cul-de-sac. Back here is the recto-uterine pouch or posterior cul-de-sac. And when there's a cyst on the ovary transabdominally, sometimes we can make out where it is. Very hard to see, if not impossible to see the ovaries in a transabdominal approach. This is what happens when you have an empty bladder or a very almost empty bladder in a transverse plane. Things look really confusing. Okay, so you can imagine this is the vaginal area down here. Vaginal vault is down here. This is the empty bladder, and this is the fundus of the uterus up here. And so the uterus sort of went behind the screen into the wall and then back out towards the screen again behind this empty bladder. And I think the anatomy is a little bit confusing when you have a really sharply anteverted uterus, and the reason it's so sharply anteverted, again, is the empty bladder. So try to scan these uteri in when you've got full bladders. It makes the anatomy much easier to conceptualize, I think. Now, endovaginally, this is an endocavitary approach, and you got to prepare the patient for this. You have to explain what you're going to do, because I feel like sometimes I don't explain it well enough, and I come back in the room, and the patient still has their underwear on, right? How often does that happen? Then you got to leave the room again. So I explain everything to them in a very clear way. Make sure they have an empty bladder. Many times I tell them, you're going to need to void, and then as soon as you're about to leave the bathroom, I want you to go and void a second time. The bladder just needs to be extremely empty. And for whatever reason, some people just they have some post-void residual in there, and it requires that we abort the procedure in the middle of it. They have to go back to the bathroom, urinate again. So I tell them to void twice before they come back, and that's really critical. In a sagittal view, your indicator is going to be towards the ceiling, and in a coronal view, your indicator is to the patient's right leg in this fashion. So the probe, the scan head, is like this in a coronal plane. The other thing is, in that sagittal view, you'll notice that the handle needs to go down towards the bed, which is why it's critical to have the patient in a gyne table, or when they're not in a gyne table, to be up on a stack of towels. I used to put them on an upside-down bedpan, but that's really uncomfortable to patients. It's better to kind of get some sheets and make a little ramp for their buttocks to go up on, so their buttocks are sitting up on this ramp, and then that way the handle, in order to see more anteriorly, you need to push the handle down to look up anteriorly, and there needs to be a place for the handle to go. Otherwise, you're pushing the handle into the bed, and that's sort of uncomfortable and difficult, if not impossible, to do. Now, as I mentioned, it's critical to have an empty bladder. If you don't have an empty bladder, what happens is you get all these artifacts. You see all this artifactual stuff over here? That's this stuff coming over here and causing artifact and obscuring the gestational sac. Unfortunately, I cannot make any sense out of what's going on in that gestational sac. We have to stop the ultrasound. The patient has to go void again, and therein lies the problem. So you got to have an empty bladder.
You have a catheter right there on the table?
I have not done that before. If it was indicated, I might do it. If the patient was too sick, or they're unstable, I'm worried about an ectopic pregnancy, but there's too much urine in the bladder, that's a good thought. At that point, I would just have the nurse, maybe there's a catheter in the room already, hopefully. If not, if the nurse has to leave to get one, I'm in the middle of my pelvic ultrasound, I'm going to have to stop the ultrasound because now I don't have my chaperone. So it kind of depends on, that's why it's nice to have an extra person, an extra chaperone in the room, not just using the nurse as your chaperone, because in an unstable patient, because you may need more supplies in the middle of this that a nurse may have to run to grab and go and get. So it's good to have an extra person in the room act as your chaperone. So now what I'm going to do is I'm going to take this schematic and I'm going to rotate it to demonstrate this is a transabdominal view here. What I'm going to try to do is explain through this transabdominal schematic what we're actually doing with an endovaginal ultrasound. Does that make sense? So here we are transabdominally. This is that endovaginal canal or stripe. It terminates at the cervix, and in an anteverted uterus, this is your uterus up here. Here's your kind of your endometrium, anterior cul-de-sac, posterior cul-de-sac. Okay, now watch what we're going to do. To sort of make this into an endovaginal scan, we're going to turn the patient as if they're doing a headstand. Okay, so imagine you've got this gymnast doing a headstand, and what you're going to do next is put the probe in from above. Okay, here's the endovaginal probe. Now it's in the endovaginal vault. And here's the wedge of sound that comes out of that probe. And you can see now it's getting a little bit of that anterior cul-de-sac, a little wedge of it here. And we're seeing that posterior cul-de-sac. And that's essentially what we're doing when we do an endovaginal ultrasound. It's this simple, okay? And if you wanted to see the funness of the uterus, therefore, which way would you need to move the handle? Would you need to move the handle this way, A, or this way, B? A, exactly right. If you understood that concept, if the word A came to your mind when I said this, you've got it. That's what you really need to understand. So, and A, this way, is towards the floor. It's towards the bed. And that's why you need to be up on a stack of towels in order to see the funness of the uterus. So I get these scans back from QA, and I see a little wedge of the bladder. I see the cervix really, really well. And then I see the base of the uterus, the lower uterine segment, but I never see the fundus because I can tell that they didn't put the patient on a stack of towels, and they just couldn't get up to the fundus. I know that happens a lot. And so I'm going to take it another step here. This is a transabdominal ultrasound, right? How do I know? Well, because I can see the vaginal stripe. If I can see the vaginal stripe, therefore the probe's not in the vagina, okay? Because when we put the probe in the vagina, we no longer see the vaginal stripe. I'm going to rotate this image, and then I'm going to show you what it looks like endovaginally. Here's the endovaginal footprint of the probe. This is kind of cervix over here. Here's our lower uterine segment, and the fundus is sort of wrapping itself around this way. Here's my endometrial stripe here. Here's the bladder. It's almost empty. We're seeing some posterior acoustic enhancement from the fact that the bladder is a low attenuating structure, and that's the difference, transabdominal, endovaginal. Just to show you, when we have the handle down towards the bed or the table more, towards the floor, and with a nice empty bladder, what I'm seeing here now is more fundus, a lot more fundus when I get that handle down towards the floor. Little wedge of free fluid down here, and certainly we see a nice wedge of free fluid in that posterior cul-de-sac, kind of between the cervix and some loops of bowel going on back here. And on our transducer we use with the turbo, this is the transducer itself. This is the little sort of, some people call this the trigger, like down here. That goes to the floor, okay? And so the indicator is actually not seen in this picture, but it's up here. So that's what has to go towards the ceiling. The trigger goes down to the floor in a sagittal view. In a coronal view, the indicator up here goes to the patient's right leg, and therefore the trigger will be aimed towards the patient's left leg. Does that make sense? Okay, good. When we look for those ovaries, again, the indicator goes to the patient's right leg. Like everything else in emergency ultrasound, whenever we go transverse, indicators go to the right. And so we're getting a short axis, but because we're coming from within the body, we rename this from transverse to coronal, because it's really a sort of a lateral projection, if you will. It's a coronal view is the technical term for it. But think of it as a short axis or transverse. That's okay to think of it that way. And what we're getting is we see that uterus in that coronal plane, and once we're in that coronal plane, then we can slide out to the ovaries. So again, here we are